Welcome everyone to the panel discussion. I just want to take a moment and thank you, Angie, and for the film crew for offering this opportunity. This is something that it feels, I'm just very grateful to be able to be around people who understand this issue and are willing to talk about it. And really quick, I'll give my intro and then we'll move on to the other panelists. So once again, my name is Dylan Lundgren. I'm an addiction recovery speaker and advocate. I've been in long-term recovery for 16 years myself, and I've also been working in the addiction treatment field for that period of time. And why this is important to me is because over this period of time with the opiate crisis and just addiction in general, I've seen a lot of overdoses and a lot of relapses. And I started to notice a correlation between the amount of medication being prescribed and the rise in overdoses and relapses. And it wasn't to say that this is the cause of this, but it was something that concerned me and that I wanted to find more information about. So that's why I'm interested in this. I think that there's dialogue that needs to happen in the addiction treatment industry. And that's part of why I wanted to offer this opportunity today. And I'll say something really quick before I move on to the panelists. Addiction doesn't necessarily constitute any abuse, right? There's a difference between, physical dependence and addiction. It's a spectrum. So this isn't to say that, anyone that's physically dependent on a medication is addicted. There is a difference there. And hopefully we can talk a little bit about that as we move through the dialogue today. So on our panel, we have a few different individuals, professionals in the field of addiction and mental health treatment. And I'm going to let them introduce themselves in depth, but I'm going to just read off very briefly here. We have Dr. Sonal Patel, we have Dr. Julia Britz, and we have Christina Veselek. So Dr. Sonal Patel, I'll let you jump in.
All right, so thank you, Dylan. I'm a integrative medical physician for the last 11 years. We've been heavily involved in substance abuse and recovery through California Integrated Recovery for the last 5 years. And I would say that all of the issues presented here, unfortunately, are a lot of what we see, not just in our recovery side, but in our primary care practice as well. And I think it's led us to really examine the fact that there's a huge need to integrate mental health professionals outside of the psychiatry world within a regular practice, and we've done that. So, briefly, that's kind of what we do.
Thank you, Dr. Patel. Great to have you here. And Dr. Britz, Dr. Julia Britz.
Hi. My name's Julia Britz, and I'm a doctor of naturopathic medicine. And I'm currently based out of Sedona, Arizona, where I work as the director of naturopathic medicine for a behavioral health facility. And we do a lot of chemical dependency holistically. And I also do telemedicine. My focus has always been on mental health. So I work a lot within the spectrum of anxiety disorders, eating disorders, insomnia, and anything that helps people get better.
Awesome. Thank you, Dr. Britz. And finally, Christina Veselek.
Thank you so much, Angie and you, Dylan, for making and airing this film. I think it's very, very powerful information. I have been a licensed psychotherapist for over 30 years, and I've been working in and out of the addiction treatment field for over 30 years. I am also a mental health nutritionist. And as a mental health nutritionist, I help my clients identify what the nutritionally based biochemical imbalances are, i.e. a starving brain very often, that is driving many of these symptoms. And so I then help people find both the foods that will help their brains recover, as well as over-the-counter supplements like fish oil or an amino acid that are nutrients that allow the brain to work optimally. And I've seen so many people transform their lives once they are feeding their brains what their brain actually needs to function.
Awesome. I'm glad we're offering, as much as we're talking about the challenges, I'm glad we all have some solution-oriented strategies as well. So thank you, Christina. And now I'm going to pass it over to our panel moderator. Back to you, Angie.
All right, so we have a lot of good questions coming in. I think I want to start kind of broad because each of you have seen what you saw in the film kind of in practice. So if you want to talk a little bit about tapering, maybe someone that's in a situation like me or Shalimar or Dave, what would you suggest for someone in that situation in a complex polypharmacy problem, and how they taper? A lot of people are asking for resources, and how do you help someone taper?
I'll jump in. I'm not a medical professional, and I have to tell everybody that, so I can't give medical advice. But what I do is I help my clients identify what are the foods and the supplements that will help support their own brains in rebalancing themselves. So it's about function. And so the very first thing I do is help my clients realize that stabilizing blood sugar is absolutely crucial in stabilizing mood and behavior. When blood sugar drops because you've gone too long, say, without food or eaten a high sugar meal, adrenaline kicks in, and adrenaline makes us feel crazy. It can make us violent. It can make us irritable. It can make us have panic attacks. So I always start with diet, and frequently it's just eating 20 grams of protein every 4 hours can change somebody's life, can turn off panic attacks that people have had for 10 years. Miraculous. So I always start with food. And then I go to, what are the neurotransmitter systems that need supporting? Whether this be a street drug, like cocaine, or a prescription medication like a benzo or an SSRI, what neurotransmitter system needs supporting, and how can we do this with over-the-counter supplements? So for instance, we have found that the brain zaps, right, that occur from coming too quickly off the benzo and SSRI are often stabilized, go away, when people take fish oil or the amino acid GABA to support the electrical system in the brain, to support the actual cell membrane where all this firing is like taking place. And for some people, those supplements can make those symptoms go away. For other people, for instance, somebody's on a benzo, I will frequently recommend the amino acid L-theanine in fairly high doses, because a lot of my clients have found that L-theanine will decrease the withdrawal symptoms from a benzo. My clients will come in to me and say, well, my doctor wants me to taper off this medication by cutting it in quarters. And, by the end of the week, I'm off it. I just cut 1/4 off a day. And I very politely let them know that perhaps their doctor hasn't heard all the withdrawal stories that I have. And perhaps, because one of the things I found actually is that many of my clients don't tell their doctors when they have a withdrawal symptom because the doctor's tapering them too quickly. The doctor's tapering them really quickly. And I say, well, you told your doctor, right? No. So I feel sorry for a lot of these doctors who actually don't know because nobody's ever told them. So I recommend, and it seems like a lot of people on this film found the same thing, that no more than 10% drop per week. And sometimes even that's too fast. Sometimes it needs to be a 10% drop per month. Very, very, very slow. This is true for coming off Suboxone and methadone. Lots of people have a really hard time coming off these opioids. And again, slower is faster. No more than 10% every 2 weeks, every 4 weeks. And then you can get there.
One thing I'll add to that as well, thank you, Christina. One thing I'll add to that as well is it doesn't have to be an either or situation with some of the solutions to tapering off or making tapering off easier. And what I mean by that is there's practices that can make it a lot easier or smoother, or at least manageable. So for example, there was one woman who reduced her opiate medication by 75% just through meditation, and then there's also studies that show that yoga is better than, at least according to Bessel van der Kolk, who is like the pioneer in trauma research. He says that yoga is better than any medication anybody has ever studied for PTSD, which is a pretty bold claim. That being said, practices like yoga, meditation, these things can be used during the process of tapering or withdrawal to make it more manageable.
I'd also like to add in too. So the first thing I would tell anybody is you did not break your brain. And I can say that because I've been on benzos for, oh God, I was on Ativan for 10 years. And I can definitely sympathize. It's a lot to come off it, and it has to be your experience. It has to be your taper. And if you want to reevaluate that, if it's not working and those interdose withdrawals are really sucking, then it has to be redone. So it's not this thing that you get on where you just have to keep doing it. And that's why it's really important to have guidance, because in a taper, it can feel like every minute is a day and every day is a year. And so these decisions we make about, do I want to keep going, do I want to stop, can be really, really intense. So having a team around you can be extremely helpful. I really love when my patients can work with integrative psychiatrists that can help them with these tapers. They're not super common, so if you can find one, they can be a really, really awesome resource. I also recommend people work with any kind of integrative practitioner that specializes in mental health. So that could be a functional medicine doctor, or it could be a naturopathic medical doctor, but someone that actually does mental health specifically, because everyone is different. So even though I do absolutely love certain treatments and modalities, I also recognize that everyone's taper is going to be quite unique. And that's because everyone has a system that can be pushed in the wrong way when we're going through a lot of stress. So somebody's taper is going to potentially drop their testosterone, or the thyroid is going to become hypofunctioning, or their insomnia is going to throw off their blood sugar, or the cortisol. It's a jillion things can happen. So it's important to have someone work with you that can test for these functionally, so we can actually find out if there's ways we can mitigate some of those tapering side effects and lessen the symptoms as much as possible.
Yeah, I'll agree with Dr. Julia, because I think finding somebody that's going to find a good baseline for you is really important. And psychologically and, clinically speaking, just from a numbers perspective, what you want to see is where, the way we evaluate any patient is, where are they? And where are they physically? Where are they mentally? And can they handle it? And, there are some people, like, we take them and they do fine outpatient. We don't really need to really do too much except kind of put them on a good supplement path, and there's other people that we really have to hold their hands, and they need a really good, strong support team. And it all varies. So it really depends on your team and the team's experience and your comfort level with them, and the ability for the medical kind of team or manager or a psychological team. I look at it the same way. And I think everybody on your team should really look at it as they're treating you, not like one particular part of you, although they may have an expertise in that area. You really need to evaluate where you're going, because I've had several clients come to me thinking they were getting treatment when they just got slid onto Suboxone. So I think research is important, and then being able to pick your medical team and how they're going to treat you or taper you is really important. We're asking those questions.
Yeah, I just want to add that we have some resources on our website. People were asking for resources. If you go to medicatingnormal.com, we have a resources tab. And there's also a harm reduction guide to psychiatric drug withdrawal, so that there's a spectrum of experience. Not everybody wants to come all the way off of everything. So there can be a harm reduction way. Okay, yeah, next, I think that kind of segues what you all were talking about into the addiction world, more specifically. If we zoom in, I know that it was my experience, this part is not in the film, but my experience that when you're taken off of opiates, let's say, you're put on more psychiatric meds because we're going to treat the comorbid condition, correct? So can we talk a little bit about addiction, the current status quo addiction treatment model and using the medical model, and how does that kind of cause trouble for some patients that are unassuming?
So I'll dive in there. So like I said, the reason why I got involved in hosting this discussion was because this specific issue, and I know we haven't had a lot of time to talk about this, Angie, but it sounds like you already know, this specific issue I've noticed become more prevalent in addiction treatment over the past 5 to 10 years. And that is that when patients come into treatment, they're administered a lot of psychiatric meds. And it's not every treatment center, it's not every client, but there is a trend, there is a pattern. And there's a few different problems I've noticed with that. One I'll share really quick. So this happened about maybe 6 or 7 years ago in Florida when I was working in the addiction treatment industry. I had a client who was maybe 19 years old, had just started doing heroin, first time in treatment, got treatment early on, so she hadn't been doing it for long, but she was really willing to be there, really engaged, which in treatment isn't necessarily always the case, And so she was really engaged in my groups and was really interested in the content. But her demeanor and willingness and presence, like ability to engage, really changed over the course of her first month there. And she came up to me after a group and was in tears because she couldn't stay engaged, and she was apologizing to me. And I was like, well, what's wrong? And she said, well, these meds are really messing with me. I'm like, well, you're an adult. You can, you don't have to take them if they're hurting you, I'm not a doctor, but if something's hurting you, you don't have to go through with it. And she's like, no, you don't understand. They're telling me I have to take them, Now, I don't know what happened to this client in the long run, but that was the first moment where it was like, something's off here, and specifically in addiction treatment. So I've noticed this type of attitude from not all doctors, not all clients, but often this type of attitude where clients are administered medications as part of their addiction treatment, and then they're manipulated or forced into taking medications despite adverse effects. And just like was touched on in the film, if an adverse effect does happen, then it's usually attributed to the original condition or a new condition. And the problem with addiction is that medications, as we know, can tweak the brain chemistry. And we don't even know exactly how, right? But we do know that it happens. And there was a Dr. Montez, who's a psychiatrist, an addictionologist, and a pharmacologist. And he said in his video series on the neurobiology of addiction that all these medications that clients are getting are going to worsen addiction, meaning antidepressants, meaning benzos, meaning a lot of these psychiatric medications. That's his quote exactly, And he went on to also say that a lot of these disorders in treatment anyway for addiction are actually a result of post-acute withdrawal. So a client might come into addiction treatment, and like myself, I'm in recovery. I was depressed. It sucked at first. It gets better, but at first it sucks. I'm anxious, I'm depressed. I want to, a lot of symptoms like that could easily be targeted as a new disorder, when in reality, it's part of the healing process of recovery. It's not a separate disorder. It's a result of post-acute withdrawal. That's the way that Dr. Montez describes it, and that's my experience as well. And that's what I've seen with clients, except they get prescribed a medication. And they get prescribed a medication that might have side effects that mess with the recovery process. So last thing I'll say, I know I'm getting long-winded here, is, for example, gabapentin has been shown to block the formation of new brain synapses. Now, it doesn't take a rocket scientist to know that you need to form new brain synapses to form new behavior, right? So why are we prescribing this so commonly in addiction treatment? Or with Suboxone, which has helped some people, because this isn't about like all meds are bad and don't help. This is just discernment. You know, in what cases are they not helping and how do we know? So Suboxone can block up to 80% of a person's feelings. Now, feeling is one of the developmental tasks of recovery. In other words, we need to be able to feel and integrate, you know, mind, body, in order to recover and change. So that's my feedback on that. It's definitely an issue in treatment for sure.
I think as the current model for addiction therapy, it's medication-assisted tapering. But unfortunately, the definition of a slow taper has not been defined in the literature very clearly. So it's up to most psychiatrists to come up with their best assessment and come up with a percentage or a program. And it can be very challenging, and it can sort of lead to a lot of distrust with patients and their doctors because they feel like their doctor doesn't know what they're doing. And in all reality, most doctors are incredibly well-meaning, and they want us to feel better, and they want to make sure that we're not dealing with panic attacks. However, most of them have not been taught how to discontinue medications. This is my cat. And I think what I see most commonly is that somebody does want to cut off a medication or even a drug, and then they're put on 2, 3, 4, 5 more right after. And that's usually when I get to them at that point. And then at this particular juncture, it's really important because we want to make sure we're taking someone off a drug appropriately, and which drug we take off first is really key, because it's not, like you said, they can all sort of play a part in affecting the brain together. And so we want to make sure that we're not actually making it worse by tapering the wrong drug first, which I've seen a lot. So again, it's definitely important to work with somebody that can guide you through this and just take it one day at a time, because things can change a lot. And I've noticed people tend to have a little more trouble during the end, during those, tiny 10-year dose cuts. And that's where things might need to change again. So there's all kinds of options like Ashton manual and cross tapers and beat counting, and they're appropriate for some people, they're not appropriate for everybody. And it really does depend. It gets tricky. And that's why I love the boards, because you can go on these message boards and people can tell you what their experience was. It can be incredibly helpful. But also, word of caution, people will tell you their most horrible stories on there. So don't let it scare you too much. And just know that if you do this thoughtfully, it can be a very tolerable experience.
Just to clarify, when she said the boards, just for the audience that doesn't know what she meant, she's talking about peer support groups that are online. There's groups on Facebook, Surviving Antidepressants, Benzo Buddies. There's all these like anonymous peer forums where people are helping each other taper off in absence of medical help. Okay, continue, sorry.
No, that's it, you got me.
So I'll hit it from kind of my viewpoint, and just coming from a primary care side, transitioning into helping folks with substance abuse. The fundamental problem, I think, and you experienced in yourself, coming across a lot of people experiences, is that not one person, as I'm speaking from the medical community, really ever follows their patients. I mean, outside of primary care, and if you're doing the regular job, you're seeing them for a few minutes here. You might not see them again for a few months. And the issue is that to build that experience up and to translate that into training, you really need people that have seen what happens from beginning to end, and then transitioning these people, not just from, okay, now we're going to put you in this program, but watching them, how do we get them off of these drugs, and to compile it. There's very few individuals that actually do that type of stuff and have that type of experience to share. And when they do, a lot of times they're ostracized anyhow. So they don't get any mainstream time to really train new personnel. So then you have this system where you just recycle bits and pieces, and you have, like you said, well-meaning individuals. I think they're all really well-meaning. I don't think anybody went into the well, there's a few, I'm sure, but most people don't go into it with some sense of altruism. But what you end up doing, unless you actively disengage from that system and choose to get educated and really talk to your patients and understand what's going on with them, you just become part of the problem. And the issue here is it goes deeper, especially from the substance abuse standpoint, because one of the intro, if I get a nervous patient, usually is tell them, like, look, I'm not trying to trade my stuff for your stuff, right? Like, number one, we need to really identify what's going on. And speaking to what you alluded to earlier, Dylan, the biggest issue is, what's at the base here so that we can address that. Is it a neurotransmitter issue? Is it a hormone issue? Like, yeah, you've been doing opiates for 5 years. As soon as you withdraw, you're going to feel depressed. You might get anxiety. And typically, if it's a downer, you're going to get more anxious. You're going to get more, withdrawn if you've been doing stimulants. So I think the general public, because they don't deal with the intricacies of the drugs, are actually better people of anticipating withdrawal symptoms than your medical professionals are, because you're looking at it from too much of a closed-in angle, and you're looking at it under a microscope. Whereas really what helps people with substance abuse in specific is the wide angle view. It's like, all right, let's get you off of this first in a safe way. And I'm all for extended tapers, but a lot of times, especially if they're in an acute issue, you do have to taper them in a relatively fast fashion. And it may help to actually put them in a supervised place where they're not pushing drugs and they're just watching them for the things that you ask them to be watched for. And they see people. I think a lot of times people go into treatment and they're just remotely monitored. You doing all right? What are your withdrawal symptoms like? Yeah, it's all right. And I think you need to really wind them into good whole person based therapy, so that we can, and assessment, so that you can really determine, the post-acute withdrawal versus what's at the base. And then the same people, I think the continuity of care is really important here, have to kind of follow this person. And now we're doing a lot of remote stuff, so I think it's a little easier. But you get into the business of this stuff, and it doesn't pay to follow somebody post their inpatient or post their outpatient therapy time, because individual therapy doesn't pay as much as it does as group therapy or whatnot. So then there's a lot of confounding factors. But from a substance abuse standpoint, Angela, we really have to look at why the problem exists and why it's so hard to get off of drugs. So you're just trained, honestly, you're trained to just put people on stuff. You're not really trained in the intricacies of taking people off.
Thank you for that, Dr. Patel. There's a lot of sort of comments in the chat as well that I want to respond to. But I'd like to start by talking about post-acute withdrawal for a minute, because in the studies that I and my colleagues have found, much of the time, the symptoms of post-acute withdrawal are actually due to two things. They're due to dropping blood sugar. The research we found is looking like something like 95, 98% of people with substance use disorders appear to be medically diagnosable with hypoglycemia. This is enormous. This means that overabundance of adrenaline and insulin is driving a lot of these symptoms. And so stabilizing that takes away a good half of post-acute withdrawal symptoms. Just try it, and ask your clients or ask yourselves, if you're in recovery, the last time I had a slip, when was the last time I ate protein prior to my slip, prior to my craving, prior to my emotional outburst? And frequently you'll find that you haven't eaten for 4, 8, 12 hours. So that's one issue. The other issue is depleted neurotransmitters. which we can rebuild using amino acids in the presence of cofactors very, very, very quickly, very powerfully. Using some of these, using food and amino acids, I've been able to turn off cravings in my clients, and they've been able to turn off cravings for themselves. I want to empower my clients to take care of their brain for the rest of their lives. I don't want them dependent on me. So they can turn off a craving within 20 minutes, which is just remarkable. And then somebody mentioned some of the psychosocial tools for reducing anxiety, etc. And absolutely, EFT, EMDR. I teach all my clients how to do their own eye movement therapy at home. So again, they're not dependent upon their therapist. It can reduce anxiety and overwhelm within 5 minutes. Very, very, very powerful. The yoga you were talking about, Dylan, just breathing, just walking. You know, there's so many tools that we have that we just really want to be teaching our clients over and over and over again. But our clients have to have an online brain in order to learn and access these tools. And so this is what I teach my students in my academy, is how to help their clients have an online brain so that they can engage in all the other aspects of recovery.
Before we move to the next question, I just want to make a clarification because of some of the comments that we're seeing that kind of Dylan talked about it earlier about there's a difference between addiction and dependence. And so I just want to briefly define that just so that everybody's kind of clear that the patients that you saw in the film were would be considered physiologically dependent, meaning their body has gone through adaptation at the neuronal level of the brain and central nervous system, that the body kind of adapts to the drug in the system, right? Now, most of the time, people taking their drugs as prescribed, like me, I never craved it, I never bought it, I never ran out early, I just took it exactly as prescribed. So it's kind of sneaky because you think, I'm not addicted, I'm totally fine. You know, I'm taking it, I'm listening to my doctor, and then little do you find out later that, oh my God, when I tried to come off of it, now I'm going through withdrawal, but I wasn't ever addicted to it. So there's just some brief differences, but that's not to say that I'm trying to stigmatize people with addiction. Is to say that the treatment can be different, right? So 12 steps might work for someone that has an addiction with opiates, for instance, but might not work with a woman that took her Prozac for 30 years and just decides to come off. It's two different treatment modalities. You would go to two different places probably. You might be seen on an outpatient basis for one and an inpatient basis for another. So I just wanted to clarify that really quick, that there's differences, and there's even something called pseudo addiction, where you take it and your body starts to build tolerance. You might take some more. So it looks like addiction in the outpatient or inpatient treatment setting, but it's really due to your body got adapted to it and you started taking more. So I just wanted to be clear about that. I know we have like an audience with a lot of different people in it. So I just want to say that before we go in to the next question. Okay, the next question is a big one. It's a hot potato, but I think you're all up to it. Okay, so since we are critically thinking about all things mental health, is addiction a disease, quote unquote? Isn't labeling it as such just more labels for which there are more meds and more treatment? Not that dissimilar for what happened to the characters in the film with psychiatry and the biomedical model of mental illness. Calling it a disease can also be a self-fulfilling prophecy, a hopeless message, meaning like there's nothing I can do about it. But I suspect it was done for financial reasons, because if it's a disease and it has a billing code, then money can be made. What do you think about the hot potato question of the evening?
I love it.
Let's dig in.
Okay, I think this is an important topic. So I don't like to use a lot of labels. I don't like to be labeled. I've been diagnosed with everything, as I'm sure a lot of people have, and I'm not sure how helpful they are. I think they can be in the short term, but I'm going back to disease for a minute. So if I think of disease as a predictable set of symptoms with a predictable outcome that tends to get worse over time without treatment, then absolutely addiction is a disease. However, I think this has been a classic discussion, especially in the 12-step groups, where how helpful is it? And do I have control? And how much is willpower a factor in all of this? And I think that can be very important to think about because there is a fine line between self-blame and self-responsibility. In terms of like, when do we go out and do something? When are we ready to go get treatment? Because I knew I needed treatment for a long time, but I was not ready to do it for a long time because that's just how it was. And that's okay. So I think more than anything, the stigma that goes along with mental illness and goes along with addiction can be incredibly damaging and painful. So whatever we can do to find compassion within that, meaning how do we find a way to see ourselves in a kind light, then do that. Like for me, it actually helps me to see it like as, you know, a disease because I see it from the medical perspective. And it helps me know that there's something I can call it. I can put it a little bit separate from me. I can see myself as the person. I can see this as the problem. I don't have to take it on as an identity. So for me, it's helpful. Now, for other people, it could be quite harmful and damaging to the ego, in which case I'd say ditch it and don't do it. So I guess it depends on your perspective and what works for you. But really, it's a very personal journey to go through. And when I say addiction, I'm kind of using it as sort of an all-encompassing word, but I do want to separate that. So chemical dependency is this physiological need to feel normal, but it needs something to do that. Addiction is a lot more psychological. Like you can get addicted to Facebook, but chemical dependency on Facebook, not really going to happen. So what will happen over time is that someone may have been put on a medication like Effexor for migraines, okay? After 30 years, now they're physically dependent on it, but not really psychologically addicted. Now, I will see people when they're coming off the medication start to experience a bit of psychological dependency or addiction on the medication as they taper because the tapering symptoms are now so painful, it's become quite scary. And there is a relationship we form to drugs. So it does overlap, but they are quite different. So I'll just wrap it up there. Thank you.
There was a study that was cited in the this documentary, The Business of Recovery, and I think it was Dr. Miller. But the study said that in this study that those who believed in the disease model were less likely to recover. And I don't necessarily agree with that wholeheartedly, but I think it is something to consider. And for me, what I've seen is a balance between, yes, there's this thing that I don't have control over, but there's also actions that I do have control over, which should I choose to take those actions, they will affect that thing I'm powerless over, you know? And it's this kind of balance of both that I've seen. And I want to touch briefly, and maybe Dr. Britz or Angie, you might throw some of your feedback in here too. The way that I look at it in terms of addiction and dependence is a spectrum. So I wouldn't want anyone to walk away thinking that because they're taking a medication or they're addicted, right? At the same time, I wouldn't want someone to walk away thinking that if they're dependent, that addiction is off the table, right? So they can coincide, or one can lead to the other, but it won't necessarily always be that way. However, there are some clients I've met that find, for example, that when they go to get off Suboxone, right, that they can't because the detox is worse than heroin, right? And this is a big part of how the opiate crisis got to this point. When the Oxycontin was starting to be taken down and doctors were starting to kind of pull away from that, people would go to the streets for heroin, and that did lead to addiction, you know? So it's not like they're that separate, although I definitely appreciate that distinction. I just want, want that to be part of that too.
I can speak to the difference in my mind between addiction and dependency, but I'd like to start with talking about what I personally have found useful in my practice and maybe in my life with the disease concept is that, in the past, society used to see addiction, whether it be alcoholism or whatever that destroyed people's lives and destroyed families, as a moral disorder and due to lack of willpower. And what you just have to do is just stop. And you just have to pull yourself up by your bootstraps. And what's wrong with you that your life has, gone to hell in a handbasket? Something's wrong with you as a person. And to my mind, the idea of disease, and I don't actually like that word, but what I do like is the science that has shown that people with substance use disorders, as well as process disorders, there's actually something changing in the brain. That this loss of willpower isn't just because you're a weak person, but there are actually very measurable physiological changes in your brain that are very hard to fight against. And that by understanding that, it can reduce your shame and your guilt and your sense of being a failure, but it also means that you can work with it. That if you understand what some of these actual physiological mechanisms are, that these things can be addressed. And very often these things can be addressed nutritionally and biochemically without a mood-altering medication. So it can be a way out for some people, and it can be a way of relieving shame for some people. So that's why I don't dislike the term when you're not using it to hit somebody over the head with, and we're not using it to prescribe more medication with. Let's understand that there is some real physiological measurable processes happening in the brain in the addictive process. And it is a process, we can see early, middle, and late stage addiction. People's experience is very different. In late stage addiction, people say need alcohol in order to get up in the morning because they're shaking so hard that unless they have a drink, they can't tie their shoes. Well, that's very different from what's happening in very early stage alcohol use, right? Well, it's because these neurotransmitters have become so profoundly depleted. And we can do something about that through feeding the brain optimally. This is where the hope is. I'll stop there, but I'm noticing in chat that there's some talk about trauma that I'd like to get to down the road as well.
Let's let Dr. Patel answer, and then we'll segue into trauma.
My answer is real simple in this. It's like somebody comes to me, I'm not really interested in, even my thoughts or their thoughts on addiction versus label. It's like, if you can come to me and we can have a straight, real meeting and determine that there is an issue, then we just start there. It's like, hey, look, let's not be blind to the issue. I don't care how you process it, because your processing the day that you come in is going to be a lot different than how you view yourself or the disease model or the addiction or dependency 6 months from now, which is going to be different from a year from now. And, it's a constantly evolving definition for the client themselves, because then they start realizing it's like, man, I just don't, I might have issues that, and I think this is what leads to people when you're, like, say, gastric bypass, is a great example. We have plenty of patients that come in and they thought they had a food issue, so they dealt with it with gastric bypass, and now they have an alcohol issue. Then when they can't drink anymore, they have like another substance issue. And the bottom line is that nobody ever looked at it like there's something deeper here. And I think that's kind of where our conversation in the chat room's heading. So I'll hold off and let you handle that. But, I don't really look at it as a disease, I think it really is just a label, and we just need to identify what the problems are.
I want to give I don't know, a few words before we segue into trauma. That in preparation for this discussion and the little bit of training that I got in social work school that I kind of like had to go after, I think we can do ourselves a disservice when we say it's either or. It's either a disease or it's a problem with your willpower. There's a whole lot in between there. There's a really good talk on YouTube. It's called Why Addiction Isn't a Disease by a neuroscientist named Mark Lewis. And he basically said, and this might be super controversial, but I'm all for critically thinking whatever's going to help someone recover whatever way that they need to. It's always helpful to have different choices to choose from, right? So he said that basically it's like a high intensity learning. It's a skill that you learn. Just when you drink a coffee in the morning, you learn that coffee works, it wakes me up, so I'm going to do it tomorrow. With drugs and alcohol, it's just a very salient experience, and it hijacks your body and it feels amazing. And I mean, when I worked in an addiction treatment center, I said, we do it because it works. It feels great. Why would you not want to do it if that's at your disposal? That we don't need to blame ourselves for that. It just, it is what it is. But also, and the last point I wanted to make was that, yes, when there's changes in the brain, there's changes in the brain when I do jumping jacks. There's changes in the brain when I have sex. There's changes in the brain when I eat sugar. Just because there's a change does not mean it's necessarily a pathology, which I think was kind of mentioned in the film. So I wanted to bring it back to that really quick. So yes, let's talk about trauma impacting addiction, trauma impacting mental health. And then we're going to have to close because we're getting close to time in about 15 minutes. Who wants to start with trauma?
I'm a trauma therapist. I've been working with trauma my whole life. I've struggled through enormous PTSD from a wide variety of trauma in my life. And it's taken me a very long time to heal from my own personal trauma in layers and more layers and more layers. And, one of the things I wanted to share that I didn't during the introduction is that I spent the first half of my life, very seriously depressed and very seriously anxious with a lot of social anxiety and ADHD. And it somehow never occurred to my parents or myself, and I'm very grateful, to go to a doctor for medication. I just found all these different ways of overcoming it, both biochemically. There are a lot of biochemical drivers of my depression and anxiety, which I had to discover layer by layer by layer. It's one of the reasons why I'm passionate about teaching this approach to other clinicians, because I've experienced the power of it in my own recovery. But so much of my depression and social anxiety was also due to trauma. And teasing that out, what part was biochemical, food allergies, nutrient deficiencies, etc., and what part of it was trauma and bullying and loss and right? Intertwined together. And I think both as clinicians and as human beings, we're always in the process of untwining it and pulling in all the resources, whether they be, nutritional, whether they be psychosocial and support, and, all of these wonderful healing methods that have been mentioned in the chat. Healing is multimodal, and healing takes time and compassion and love and patience and creativity. And I've certainly gone down some dead ends in my healing process. And it was like, oh, well, that costs a lot of money, didn't get me anywhere. And then, ooh, this is working. Ooh, I'm going to do more of this. So I just want to be so encouraging to all of you out there, is that we can recover and we can move out of darkness into life, and we can transform and create for ourselves a life worth living. And we just need to do it step by step by step, and keep finding the resources that work for us. What works for me may not work for you or you or you, but there's so many wonderful resources out there now that weren't available when I was 20, 30, or even 40.
All right, I'll take it's a huge question. So if I start rambling, just stop me, Angie. But from in one of my notes from the film actually says, the issue what we have with PTSD and chronic stress. I think there's plenty of research out there. Nobody wants to look at it because it's not really a medication-based approach. But when you look at chronic stress, trauma, and the physiological, not just the biochemical, but there's physiological changes that occur in your brain and higher order functioning. And then I did see somebody had mentioned the work of Dr. Gabor Mate, who I have a lot of respect for. And, briefly for anybody that doesn't know, he talks a lot about even in utero exposure to stress, signaling and brain formation, the formative period from 0 to 5, and then 5 to preteen, teen years. And then you're pretty much set. I mean, those are formative years of brain development. So it leaves these windows open so that certain people, when they get exposure to substances in general, what's all loosely defined as just, any chemical, I don't care if it's a legal, illegal drug or whatnot, you form an affinity for that. Because it helps bridge some of those gaps that you may have had. It makes you feel better, right? And it's like you said, it's like you don't do anything unless it makes you feel better on some level. But a lot of the trauma that we're looking at and a lot of the substances people end up on, I mean, they're like, they're like biochemical hugs, man. They're like hugs they never got as kids, or hugs that they never got. It's trauma that you just never. Nobody, the modern medical approach at this point is really just, hey, let me write you something and get you out of my office so I can move on to the next person because I got to keep this place open. And the conversation that never happens is, hey, wait a minute, like, let's go back. And when you go into psychotherapy, the system's great. Like if you look at it from like, are we ever going to solve the problem and keep these people hooked perspective? Because when you go into psychotherapy, it's like, well, let's start as a child, and let's work up. And it's never like, let's start where you are and let's work to the point where you're functional. Then maybe that's not such an issue, or maybe it is an issue, but we deal with that. But let's get you functional first. And like function is not an issue any longer. It's what I think is good for you is what we're going to do. And I think that these conversations, and you're going to go far with this, these conversations really need to go, what the hell are we doing with our kids? Like what are we doing with them? And why are we not giving them coping mechanisms? Or are we that freaking numb that we're not paying enough attention to them to help them form robust coping mechanisms to kind of move this forward? And I think that's where, fundamentally speaking, if we're really going to form strong communities and have this insulation against a biochemical hug, so to speak, we need to start with like what we're doing in our homes and how we're forming alliances and relationships with each other. And I know this is a big thing that you do, Dylan, is your whole thesis, so to speak, and your TED talk and everything revolves around the ability to form emotional connections again. And you're not going to replace that with a pill or a drug or a substance. So I think, my one sentence kind of synopsis here is that like we really need to look at what trauma does to a brain. How do we repair it? What things do we do once? Because the brain's plastic. Dr. Julia just alluded to that, right? The brain's freaking plastic, man. It just takes longer when you're older. And there are substances like naltrexone that kind of help speed up the plasticity, which we use extensively. but there's ways to do it. There's documented, well-formed research ways to do it. But I mean, we have to shine the light on that because we already know what the status quo is.
I love how you said that, Dr. Patel. I think that was spot on. And just to add, I think trauma is, it's definitely, I mean, I don't see a case that there's not trauma. So what that trauma is, who can say? I mean, my example I always give is if you have 3 children, age 12, age 6, and then 6-month-old, and they witness something kind of scary, like a parent's fight that was kind of maybe bad. Everyone's going to worry about, oh, hey, like that 12-year-old and that 6-year-old, are they okay? And no one really worries about the 6-month-old because we think they're too young, you know, but they did see it. So, and then add on the next layer of, well, maybe the 12-year-old's really, really sensitive. And maybe that was a bit too much for their nervous system. And maybe the 6-year-old just doesn't really care. They got like a hardy constitution, it didn't bother them. So the level of trauma and what that means is so personal and so specific. And I've seen it absolutely be the root of schizophrenia or bipolar. So in terms of how to deal with that, I love that Christina does do trauma therapy. I think that's amazing because it's something very specific and can be incredibly helpful. And I would say whenever people are ready to go into it, because it can be very, very scary, even the concept of thinking about trauma can get people really amped up. So it's one of those things that I always encourage people, like, it's your taper, it's your process, it's your healing journey, it's your dive into therapy, you know, and whenever you want to do that, it's really up to you, because if anyone forces you to do it, it's probably not going to go very well. You know, when patients call me and they say, or actually rather their spouses call and say, hey, I want to get my wife in. Okay, they have to call me because I can't be on, you know what I'm saying? Like, I want people to be ready. I've had therapists tell me, like, hey, do you want this? And I'm like, kind of. And say, okay, then we'll talk again when you're ready. And how offensive, right? But it's true, you know, so it really is a personal journey, and it really is something you got to do when you're ready. And that will make it not scary. Like, I don't know if you guys remember this show. It was called The OCD Project. And it was really, really intense exposures of like making people do awful things like toilet seats and stuff. And so, you know, for me, it was like, wow, scary. Therapy seems very scary. It seems really intense. It seems like you got to dive right in. And in all reality, that's not the case at all. And all of this should go at your pace. And that's the beautiful thing about some subspecialties like psychotherapy, integrative medicine, functional medicine, is that you will get more time and it will be at your pace, because ultimately, like, this shouldn't be scary. Like, the taper's already going to be scary. Like, everything else around it should be comforting. So
That's right.
I just want to take a minute to plug, we did get into the Trauma Research Foundation Film Festival, their first ever. That's Bessel van der Kolk's organization. So we are having a screening with them on, hold on, that's where I was looking at my phone. It is on December 1st through the 6th. Our screening is going to be December 6th. I can't promise anything, but we're trying really hard to get Bessel van der Kolk to be a panelist. So everybody cross your fingers. But anyway, so I just wanted to say that while we were talking about the trauma, and I put the link below. Okay.
Awesome.
Anybody else want to last words about trauma? Dylan, yes.
Ben, so first off, thank you for mentioning Gabor Mate. I was going to bring him up too, Dr. Patel. And something that he mentioned was we can't just hand out more and more medications, but we have to look at the social and environmental factors, the stressors that are underlying these issues or these conditions, you know, and I love that, because I think, not just think, but I've seen the impact that holistic practices, nutrition, like basic general health principles can have when they're integrated into a community setting. You know, like, I've been with these concerns a lot of times alone, and it's pretty dark, you know, it's pretty depressing to be with this alone. And yet there's other people out there who have struggled with this, who share these concerns, and now we're together in this little community setting. And I'm guessing everyone else feels a sense of camaraderie and hope in that, you know. And it goes for the same thing with some of these challenges, especially like trauma, you know, and trauma and addiction are very closely related. There's a study called the ACEs study, And the ACE study showed that the more adverse childhood experiences that somebody has, the more likely they are to suffer from an addiction later on. And an adverse childhood experience is basically trauma. You know, it's a situation that somebody feels powerless over. And like Dr. Britz was saying, you know, trauma can be subjective, you know, but the one thing that it is painful. You know, it's like repressed, stored pain. And for me, the personal experience of trauma showed up as OCD. So in my recovery from drug and alcohol addiction, I started to suffer from OCD. Now I'd always kind of had that, but I think the drugs were like that, you know, that biochemical hug, you know, and there's no shame around these things. You know, that's something I wanted to say too. It's like, this is just a natural human tendency, right? To avoid pain and seek pleasure. But when it gets to be counterproductive, you know, I want to support people in moving away from that if that's what they want, you know. But when I suffered from OCD, it was a logical compulsion, but it was fueled by a physical sensation. So there was this feeling of like, I have to check, you know, for me, it was like checking documents at work. You know, my mind was like, I have to check these documents, but the feeling was like, I have to, you know, it was like a physical compulsion. And I did this emotional healing work, very similar to what Bessel van der Kolk talks about. And it was actually based in part on a doctor called Dr. Janoff. And Dr. Janoff developed a technique called primal therapy. And the technique I used was called fear memory integration. And it basically was getting into a position where I'm starting to listen to my body and just sit with the pain and express the pain from the sensations in my body, as opposed to cognitive behavioral therapy where I'm just talking about it. You know, and when I learned, it's a little hard to explain, but for me, I wanted to give a plug for that because it was so impactful. And for me, having a space where I could be and sit with my body and learn the language of my body rather than the language of my mind, and start to express the emotions from the body, not the mind, healing started to happen. And I started to tap into some old memories that had been fueling a lot of this neurotic behavior. And as I tapped into those memories and expressed that pain, the OCD symptoms reduced and have never returned to the same place again. This was over a decade ago. You know, I'm still a little neurotic at times, but, you know, I would say they dropped anywhere from 50 to 75% and never returned again. And that's without medication. You know, that being said, real quick, I did have to use medication for a short period of time, which is fine, because I was so out of my mind, I couldn't work. I had to take a leave of absence from work. I was having emotional breakdowns every day. And so I had medication for a period of time, and it helped take the edge off. But I noticed that it also was keeping me from feeling the pain. So there was a point where it's like, okay, I'm going to have to, you know, wean back off this. And I did. But there is a way out. You know, there's definitely a way out. And I think it's a matter of finding the people that have real solutions, right? And are moving in the direction, or have moved in the direction that we want to move in. And I think having the discernment to really know what that is and what those are is really important, because there's a lot of misinformation in terms of this stuff. And it might not be intentional, but it is out there. So that's why I really appreciate all of you and the willingness to be here today. That's it for me. Thanks.
I just want to, there's a question. I was going to not ask it, but I think it's really important. So can we do like a lightning round? Like answer as quickly as you can, and then we'll do closing thoughts. But this is seriously important, and kind of what you just said, Dylan. This person's asking, and I'm going to make it more general. How do you know the treatment or the medications that you're currently receiving are helping you or hurting you? Who wants to answer?
So I'll jump in real quick since you just
said it pretty much. Yeah.
So how do you know if something's hurting you or helping you? Having a metric to go by that's objective, I think it can be really, really helpful. So having a metric that you agree on with somebody that you're accountable to. So that could be a therapist, that could be a doctor, that could be a 12-step sponsor, it could be, you know. So the metric might be, for me with OCD, it's, you know, I don't feel as out of control, and I'm not checking documents 20 times a day, 30 times, whatever it is, you know, but an objective measurement rather than just the feelings. I think there's going to be something in physical reality that I can measure that shows, you know, this is getting better. I hope that makes sense.
I would agree with you, Dylan. I think though sometimes it's hard to measure emotional pain. It's hard to measure, depression, anxiety, all of that. But I still think it's important to, even if you're using like a 0 to 10 scale, today is my, emotional pain at a, 2, a 5, or a 15 on a 0 to 10 scale, because I've had so many clients come in on a bunch of medication, and I ask, well, when did you get on the medication? And is it helping? And I very often get the answer of, for somebody who's been on it for 10 years, well, it helped at first. And I use a assessment tool that we call it looks at neurotransmitter deficiency symptoms. And it's a pretty accurate assessment tool, actually. And let's say this person has been on an SSRI for 10 years, and they've got 10s all through the symptom of serotonin deficiency. Well, that med's not working for them anymore. Maybe it was working for them 10 years ago. Maybe it worked for them for the first year, but it's certainly not working now. So if somebody's still having intense symptoms and they've been on a drug for a long time, or going to, certain types of therapy for a long time, and nothing's changing, it's not working for you. When you find the right thing, change can happen really, really fast. Therapy does not have to take, 20 years. Now, I say this having been in recovery my whole life, but things heal by layers, but things can happen really fast, and there are very powerful modalities out there. And if you don't think your modality is bearing fruit, start looking for some other ones.
I would say the first thing I ask my clients is, why did you get on the medication in the first place? And is it doing what it's supposed to do? And how well is it doing what it's supposed to do? And then I ask, okay, are you getting any side effects from that? And then we go into the foundations. Okay, how's your sleep? How's your digestion? How many bowel movements are you having a day? So we look at all that together, and then I allow them to come up with an assessment. If they sound like, yeah, I think this actually is helping, or like, no, it's not doing so much. And obviously it gets confusing when there's multiple medications. But generally speaking, there's also an intuition there too. And for a lot of people, going off a medication on accident, like maybe a dose was forgotten, right? You forgot to take your bedtime dose. You woke up and you're not feeling so good now. Sometimes that's enough to scare a lot of people when they experience what that feels like, especially if it's a short-acting drug. And maybe it does help the anxiety, but when they realize what else it's doing, does put it in perspective. So I don't know if there's a very objective answer, at least that I consider, but I try to suggest to people to look at it on paper and consider what it's doing from the entire perspective, if possible.
Dr. Patel, lightning round.
Lightning round. All right. The very basic question is it helping? How do you know if it's helping you or hurting you? It's real easy. Does it make you more functional? Yes or no? Are you more functional with it or without it? And if it's hurting you, are you less functional with the medication than you are without it? And I think if you could answer those questions like objectively, or just make a little chart for yourself, you can kind of start that process, so you have something to take when you go in with a clinician and say, all right, these are the things that I see with this medication, positive, negative, and then we can address that from there.
All right, thank you so much. So now we're gonna go to the part where we all give our last thoughts and kind of wrap up. Please share where people can talk to you, where they can seek you out if they want more information. And let's go ahead and do one at a time.
All right, I'll start since I was the last one to go. All right, we, for the integrative medical practice, We have a website, valleynh.com. I'll type it in here in a couple seconds. And then for the substance abuse, we have a Facebook page as well. And then, Facebook, LinkedIn, website. And Facebook, LinkedIn, website for the integrative mental health side as well. And that's CA as in California, Integrative Recovery Centers, or CIRC. That's out of Fresno, California.
You can find me at Alternative to Med Center. That's www.alternativetomeds.com, or at my personal website, Dr. Julia Britz, and that's there's no period after the doctor. So Dr. Julia Britz, BRITZ.com. Oh, and my OCD Diary.com. That's my blog.
I run the school, the Academy for Addiction and Mental Health Nutrition. I've just, we'll just post it in the chat there. So www.addictionnutritionacademy.com, information about our courses, articles, all sorts of things. But I welcome phone calls. I welcome emails. My phone number is 303-888-9617. And my email address is christinaveselek@gmail.com. And I would love to chat with anybody about any of this as you want to.
All right. Angie, do I have like maybe 3 minutes?
Yeah, of course. Go ahead.
Something. So I want to give a little more context to this. First off, I just want to thank all the panelists for jumping on this. You know, I was really excited when you said yes. I was like, okay, cool. Can actually do this now. There's doctors on here. But thank you for being part of this. And, you know, once again, my reason for doing this is because of massive concern of how this is playing out in the addiction treatment industry. So in the year 2000, the Drug Addiction Treatment Act was passed. And what this meant was that Schedule 2, 3, 4, and 5 drugs could be administered in addiction treatment, which up to that point was illegal or highly regulated, like methadone clinics. So that was in 2000. Since 2000, just one of those classes, benzos, fatal overdoses, have quadrupled. Okay, that's just in one class out of all of those. The premise is, the reason for that is because a lot of people are starting to suffer from addiction, and they're seeking help, and they're starting to get some of these medications. That's just a theory. But my concern is that I've seen this happen at addiction treatment. And I've seen a client prescribed a stimulant, an opiate, a benzo, and gabapentin as part of his addiction treatment by an addiction treatment professional numerous times a day at almost the highest dose of each day. And despite relapsing to his drug of choice, it wasn't changed regardless of my input, right? And unfortunately, this isn't, you know, like this type of stuff happens, and it's highly concerning, and it's happening more. And some of these clients, unfortunately, are overdosing and dying. And we spend $30 billion a year on addiction treatment, right? The opioid addiction market, as far as medications, is supposed to be $42 billion by 2021, right? And as was said in the film, you know, a manipulated data set versus an honest data set, the difference is worth billions, right? So there's definitely times when this stuff helps, and I've seen it firsthand. There's times when it's very harmful, and there's a lot of stigma against having the conversation, right? Simply sharing this video, I was removed from an addiction professionals Facebook group, banned from the group for sharing the video. You know, this discussion. My personal or my business Facebook page was taken down, right? So there's a lot of stigma around having this conversation, and it's really important that we do it, and we do it in a way that's navigating this territory. You know, because at the end of the day, I don't want to fight. I'm not here to to like debate about medication. And this is pro-informed choice, as Angie said. And really what I'm about is improving long-term recovery rates. That's really the metric that I want to look at, so that people can live inspired, healthy lives in recovery that they want to live, right? Because I think a lot of people, that's what they want, and I want to support that. But part of getting there is shining a light on the hindrances. And this is a pretty big hindrance that I've seen to that. So if you want to follow me and be part of that, you can follow me. I'll put it in the chat. DylanLundgren.com is my website. I also have a YouTube channel where I put unique solutions and relevant information up there as well. Instagram, Facebook too. But however I can support you, feel free to reach out. Once again, I'm not a doctor, but I am passionate about helping you. So let's do this together. And thank you again for everybody. I want to leave one last thank you to my Southern Berkshire Toastmasters group for helping me do the outreach and put this together. And thank you, Angie.
Oh, thank you, Dylan. I couldn't have said that better myself. What you said was just beautiful just now. And it's something that I always say is, let this be the beginning of the conversation. Don't believe anything we said. Go let this seek out and come to your own understanding of what these things mean, without just blatantly taking, what this narrative that we have right now. There's more to it. There's more nuance. And there's more things for yourself that you can learn from it, really. So with that, I'll just tell you, if you're interested in sharing this film with other people, we have screenings all the time. On our website, there's a watch page. You can find all the upcoming screenings, and each one is different. So like, we have Mental Health Europe coming up. We have another one about psychedelics in the UK. So MDMA therapy for trauma and things like that. We have different discussions after the film. We also have a t-shirt shop that actually closes tomorrow night. So if you want a t-shirt or a sticker, you can go get that. We have a YouTube channel with more than 120 videos, some small videos just about like, is depression really a brain disorder? Are antidepressants really antidepressants? Things like that you can share, and they're small and short. And then the panel discussion will be available also on the channel. And Facebook, Twitter, and Instagram, follow us there. And again, our website is medicatingnormal.com. And if you know anyone that wants to host a screening like this one, you can email us at medicatingnormal@gmail.com. So with that, I just want to say thank you to all the panelists for your work in this area and for critically thinking about all things mental health and addiction. And just thank you for what you do. And Dylan, thank you for hosting the screening. It was excellent. Yeah. And we'll just say goodbye now. And thank you so much to the audience for coming. Have a good one.
Thank you. Thank you, everybody. Thank you, Angie.
You're welcome.
Thanks
Good
a lot,
night.
Dylan, for getting us together as well.